مش عارفه مين السكند سبيكر. اميره السيلجي، دكتوره اميره عبد المنعم. زي ما تحب. هذا بديل ازازيق خلاص ماشي. مين اللي جه؟ محمد سحر ده فين؟ Our next speaker is Professor Amira Abdel Moneam Adly, Professor of Pediatric Hematology, Ain Shams University. معلش أنا متحيزة للكلينيكال باثولوجي، شايف إن كل يتكلموا لازم
احنا ما بنعرفش نشتغل من غيرهم. بالظبط كده. بسم الله الرحمن الرحيم. First of all, I would like to thank Professor Dr. Amira Abdel for always inviting me to share in this great conference. Thanks for my chairpersons and colleagues. My presentation today will be about a new marker for an old process. The new marker is ischemia modified albumin, a new marker for an old process which is the oxidative stress in P-thalassemia major, and I will correlate this marker to the iron overload, lipid peroxidation, and vascular dysfunction. As we all know, thalassemia is a hereditary anemia resulting from defect in hemoglobin production. A mutation in beta globin gene leads to defective beta chain production, and this leads to imbalance between alpha and beta globin synthesis, and the insufficient beta globin production results in accumulation, precipitation of unpaired alpha chain, which is responsible for the pathophysiological mechanisms occur in thalassemia patients, which are ineffective erythropoiesis, chronic hemolytic anemia, and iron overload. These changes lead to instability of the generated hemoglobin or to the globin chain imbalance, which is in turn impacts the oxidative environment, both intracellular and extracellular. And the occurring oxidative stress and the inability of the body to adequately overcome it will, to large extent, contribute to the pathophysiology and all complications, morbidity, and mortality occurring in thalassemia patients. Our thalassemia patients under significant iron-driven oxidative stress, and all studies recently and from the last decade indicate the elevation of active fraction of non-transferrin bound iron and labile plasma iron in those patients. Hand in hand with increased oxidative stress, there is decrease in the antioxidant total capacity in these patients. As we all educate our patients that blood transfusion is not the only treatment of thalassemia, hand in hand with the same importance is the iron chelation, a secondary iron overload in transfusion-dependent thalassemia major occurring due to increased dietary iron absorption and repeated blood transfusion. And this leads to generation of labile iron at the inner and outer surface of red blood cells. And consequently, the excessive active iron catalyzes the production of a variety of reactive oxygen species, leading to cumulative cell damage and inflammatory changes. Therefore, effective iron chelators are required to remove the toxic ions and to prevent oxidative damage in vital organs, particularly heart and liver, the most common organ damage occurring in our thalassemia patients. And chelators can act upon different iron pools, including transferrin bound iron, non-transferrin bound iron, labile plasma iron, and free iron in the cytoplasm, to form complex chelation between the iron and the chelator, which is excreted either in urine or stool according to the mechanism of action of iron chelator. So what is oxidative stress? It's defined as the interruption of balance between oxidant and reductant within the body due to the excess production of preoxidants and free radical. And this imbalance will cause damage to the cellular components and tissues in the body, leading to oxidative stress occurs as a result of increased level of lipid peroxides and free radical intermediates at the same time with the decreased total antioxidant capacity. In thalassemia patients, there is excess production of reactive oxygen intermediates such as superoxide anion, hydroxide radical, singlet oxygen, hydrogen peroxides within the erythrocytes, and this leads to oxidative stress, leading to the possible consecutive with accelerated apoptosis, which is the premature death of the red blood cells, and leading to shortened lifespan of the erythrocytes. And this figure to show that there is intracellular oxidative events occur in the red blood cells of the thalassemia patients, hand in hand with protective mechanism. Starting with the intracellular oxidative events, it is starting with oxidative denaturation of the hemoglobin, with resulting production of reactive oxygen species, free heme and iron. Iron acts as a phantom reagent for the generation of hydroxyl radical. And again, there is an enzymatic generation of superoxide by NADPH oxidase, and there is a hemochromes, which mediates the oxidative cross-linking and phosphorylation of band 3, leading to clusterization and destruction of the cytoskeleton of the red blood cells of thalassemia patients. And also there is phosphatidylserine exposure results from reactive oxygen species induced disruption of the normal membrane organization of the thalassemic red blood cells. And here is the protective mechanisms which occurs inside the red blood cells of thalassemia patients trying to antagonize the oxidative stress. Starting with haptoglobin. Here's haptoglobin, hemoglobin, and the hemopexin heme complexes are endosized by the macrophage to overcome its antioxidant effect. And there is an antioxidant enzymes present inside the red blood cells, and there is a stress response mechanism. And lastly, there is something called protein quality control pathway. This protein quality control pathway leading to degradation of the unpaired excessive alpha chain globin, which is responsible for the polymerization and a need for oxidative stress in beta-thalassemia patients' red blood cells. So, ineffective erythropoiesis is well documented in beta-thalassemia and is attributed to the presence of excessive unpaired alpha globin. Unpaired alpha globin has the tendency to precipitate, auto-oxidize, and producing a high amount of reactive oxygen species, free heme and iron. And these molecules can promote oxidation of membrane, lipids, and protein, resulting in damage of the phosphatidylserine, which is the limiting protein present in the membrane of red blood cells, leading to premature apoptosis and death and short lifespan of the red blood cells. These are signs of eryptosis. Eryptosis, which is the premature death of the red blood cells. It has demonstrated that the presence of alpha globin precipitate in cells at the polychromatic erythroblast stage of maturation, which is the stage of increased hemoglobinization and apoptosis of beta-thalassemia erythropoiesis. And this is to say that oxidative stress starting in the bone marrow and then in the circulation of the thalassemia patients. It started by erythroid expansion and ineffective erythropoiesis, and then in the circulation there is endocytosis of red blood cells by macrophages, and there is hemolysis. It leads to release of free hemoglobin and reactive oxygen species. Hand in hand, there is a decrease in the nitric oxide bioavailability due to free hemoglobin and neutrophil activation, and there is increased expression of plasma and endothelial enzymes which give rise to more reactive oxygen species. So ineffective erythropoiesis and hemolysis give rise to chronic anemia, which results in tissue hypoxia and subsequent increase in erythropoietin production, which in turn leads to enhanced extramedullary and bone marrow erythropoiesis, which is characterized by increased erythroid proliferation. And recently, reactive oxygen species have been implicated that increased proliferation and differentiation of beta-thalassemia erythroid precursor. And a model where an increase in aerobic respiration would result in increased level of ATP that could lead to increased calcium intracellular level, possibly through activation of calcium pump. These high calcium levels inside the red blood cell stimulate oxidative phosphorylation, resulting in further increase in ATP. So increased erythroid proliferation, differentiation lead to increased metabolic rates and creating something called feedback loop and vicious circle. Therefore, even a small initial imbalance in reactive oxygen species could rapidly result in a significant negative outcome. Iron overload is well documented in thalassemia and is caused by increased both intra and extracellular oxidative denaturation of hemoglobin, and hepcidin is produced in the liver and binds to the iron exporter ferroportin or the erythrocyte. macrophages and liver, mediating its internalization and subsequent degradation, preventing iron export from these cells. Hepcidin is circulated by iron status, inflammation, hypoxia, and the erythropoietic iron demand. Its level is decreased in beta-thalassemia due to both ineffective erythropoiesis and subsequent enhanced erythropoietic activity. And oxidative stress has been implicated again in both ineffective erythropoiesis and erythrocyte proliferation. At high level, iron is an extremely toxic molecule. It can exit in circulating red blood cells and migrate from plasma to hematopoietic and endothelial cells as well as various organs. Myocarditis and liver cirrhosis and endocrinal complication are the most important complication in thalassemia, and excess iron absorbed from the GIT travels to the liver and acts as a nidus for fibrosis and liver cirrhosis. Transfusional iron, on the other hand, first accumulates in the reticuloendothelial system, and when it be saturated, it then transferred to the parenchymatous organ, especially heart and endocrine glands. The iron binding capacity of transferrin is overwhelmed by the continuous accumulation of iron, and this results in the production of non-transferrin bind iron, which is highly toxic. And the transport of non-transferrin binding iron to organ is faster than the transferrin bound iron. So the toxic iron is binding fastly and accumulates in the tissue. Moreover, myocardium specifically and endocrine tissue, unlike other tissues, have L-type voltage-dependent calcium channel which easily transports the non-transferrin binding iron. So this is the most complication we see in our patients in the heart and in the endocrine gland, because the non-transferrin binding iron transferred and binds easily to both tissues. So it's our experience. We make a study about the ischemia modified albumin as a marker of vascular dysfunction and subclinical atherosclerosis in beta thalassemia major patient. We study ischemia modified albumin. It was a marker of myocardial ischemia and stroke. And recently it was found that it is present in as a generalized elevated marker in any disease having oxidative stress. We studied 45 thalassemia patients in relation to control, and our thalassemia patients were asymptomatic to any clinical cardiac disease. And after thorough history and the clinical examination, we make an echocardiography to diagnose asymptomatic subclinical cardiac abnormalities and to diagnose patients at risk of pulmonary hypertension. None of our patients had pulmonary hypertension, but we diagnosed the risk by increasing the tricuspid regurgitant jet velocity more than 2.5 milli per second, and also measures the carotid intima media thickness as a marker of subclinical atherosclerosis due to vascular dysfunction, which is common in thalassemia patients. And we measure ischemia modified albumin and to correlate it to the malaldehyde MDA, which is a common, well-known marker of oxidative stress. And we found that, this is to say that our patients were clinically asymptomatic for cardiac disease, but 20% had cardiac disease defined by echo as a fractional shortening less than 35% and ejection fraction less than 55%, and 22% have risk of pulmonary hypertension by elevated tricuspid regurgitant jet velocity. And we found that ischemia modified albumin and malaldehyde are significantly elevated in thalassemia patients compared to the controls. And the most important that ischemia modified albumin were highly elevated in patients with heart disease defined by echo, which is asymptomatic clinically, so it's an early marker who can detect patients before the occurrence of symptomatic cardiac disease, and also elevated in patients with at risk of pulmonary hypertension, and of course elevated in patients with high serum ferritin more than 2,500. Instead, MDA, which is the common known marker of oxidative stress, it was related only to the serum ferritin, not to the complication and morbidity of thalassemia patients. And to make a cutoff value for the ischemia modified albumin, differentiate between patients at risk of pulmonary hypertension and patients at risk of heart disease. And ischemia modified albumin was significantly correlated to the MDA just to prove that it's related to the stress and elevated in correlation to the needs of MDA in thalassemia patients. Ischemia modified albumin is highly correlated to serum ferritin level and is correlated to the carotid intima media thickness, which is a marker of subclinical atherosclerosis. And so that's to say that ischemia modified albumin can be an early marker for both vascular affection in thalassemia and subclinical cardiac disease. And when we make a multiple linear regression analysis to determine the most affecting variable of ischemia modified albumin in beta thalassemia measure, the most effective is serum ferritin, followed by MDA, ejection fraction, tricuspid regurgitant jet velocity, and carotid intima media thickness. And we concluded that ischemia modified albumin significantly higher in thalassemia patient correlated with an important marker of oxidative stress, which is MDA, and correlated with the cardiopulmonary complication, including pulmonary hypertension and the cardiac complication, and the positive correlation with carotid intima media thickness make it a marker of vascular dysfunction and subclinical atherosclerosis. And oxidative stress is now an emerging point for the new researchers because it affects the cytostructure of the red blood cells, and so it will be a novel drug to improve or making cytoprotective system in the red blood cells in our thalassemia patient. And thank you.
Many thanks to Professor Amira Abdel Moneam for interesting presentation.